Hello, everyone, and welcome to our Army of Women research webinar series. Thank you so much for joining us. My name is Amaka Obidegwu, and I'm the program coordinator of the Army of Women program here at the Dr. Susan Love Research Foundation. Today, along with Dr. Susan Love, Dr. Dunya Atisha is joining us, and she's a guest speaker for our webinar series today. Dr. Atisha is a plastic and reconstructive surgeon with a special interest in restorative breast surgery, working at the Center for Women's Oncology at Moffitt Cancer Center. Dr. Atisha is also an assistant professor of plastic surgery at the University of South Florida Health, where her emphasis is on training future plastic surgeons about the principles associated with cancer reconstruction. As someone who has also trained and obtained her boards in general surgery, she works well with breast surgeons to offer comprehensive breast cancer care to her patients. Additionally, she is very well published in the area of health services and outcomes research associated with breast reconstruction. Her passion for breast cancer patients is evident in her work and her research and she hopes to be able to restore wholeness in women with breast cancer. In 2012, the Army of Women helped Dr. Atisha and her team recruit for the Evaluating Patient-Reported Outcomes in Breast Cancer study, where over 9,000 of Army of Women members signed up to participate. We are so pleased to welcome her and to have her join us for our Army of Women research and webinar and to learn more about the results of this study. And thank you everyone for participating.
Well, thank you very much. That was a really nice introduction, and I'm incredibly honored to be now amongst the Army of Women, speaking to a group of people who may or may not have even been involved in the study, but really it was just the immense passion that the people with the Army of Women have that were able to make this study possible, and it is making headway within the breast cancer world. So I'm here to talk to you today about my study called A National Snapshot of Patient-Reported Outcomes with Breast Cancer Procedures. So essentially, I'm going to summarize what exactly it is that you guys told me about your breast cancer procedures. Let's see here, probably I'm having a little bit of difficulties advancing this.
There we go.
Okay. Well, today there are more than 2.6 million breast cancer survivors in the United States, and we know that about 41 million breast cancer diagnoses will be made in the next 25 years. So with such a large population of women living with a previous history of breast cancer, there really needs to be an emphasis on focusing our research on the effect of current treatment modalities on the long-term health and well-being and satisfaction with outcome. So this year, greater than 280,000 will be diagnosed with breast cancer, and women with early-stage breast cancer are really given three different options, surgical options, each of which are equally effective in terms of cancer control and in terms of their long-term survivability. Option number one is considered breast conservation surgery, which is sometimes called lumpectomy, followed by radiation. Option number two is to just do a mastectomy without any type of reconstruction. And then option three is mastectomy with breast reconstruction. However, this is a really complex decision that needs to be made, and I think in order to help facilitate the decision-making process and in order to help improve patient outcomes as well as their quality of life in the survivorship period, surgeons and patients really need clinically relevant and scientifically sound information that reflect what patients tell us they really felt after these procedures. So today, a lot of the studies that are out there that look at patient-reported outcomes associated with breast cancer surgery are often in sort of one institution. They come out of one institution, or they don't involve a very large population of patients. They also tend to use surveys that have not necessarily been designed for a population of women that have undergone breast cancer surgery. So to circumvent those issues and to sort of help us get more targeted data, We asked you, the Army of Women, to participate in this survey study. Essentially, we asked adult women above the age of 18 with a history of breast cancer surgery in the United States. We asked you to participate by answering a series of online questionnaires. The questionnaires were the BreastQ, which is a new, really surgery-specific questionnaire that looks at quality of life outcomes, such as physical function, sexual function, and psychological function, as well as the satisfaction with your breast. And there are 3 different modules of the BreastQ. There is a BreastQ designed for patients who had a lumpectomy. There's a BreastQ designed for those with reconstruction, and there's a BreastQ designed for those who just had mastectomy. We also asked you guys to answer questions about the impact of cancer. This is another survey that is specifically focused on cancer patients. We asked questions regarding whether or not you had PTSD. There is a growing research that demonstrates that patients with certain types of cancers may actually have unrecognized post-traumatic stress disorder. And so we submitted the PTSD checklist to you. And then we asked you some basic questions about yourself, your breast cancer history, your surgical treatment history, and then some demographic data, such as your work status, your employment, your race and ethnicity, and other things. And I'm going to talk to you a little bit about all of this data. So to start with the BreastQ, because that's really what the majority of this talk is focused on, is the results of the BreastQ. We asked you the following questions in terms of satisfaction. So if you look at the questions, they're really just focused on this. For example, was the questionnaire given to women who had lumpectomies. This is asking patients about their satisfaction with their outcome. And we ask questions about, how do you look in a mirror? How do you feel in your clothes? Is it comfortable to wear a bra? So there are really, really specific questions trying to target in on what breast cancer surgical outcomes could potentially do for a patient. And then we answered similar questions to women who had reconstructed breast, and even similar questions to those who had mastectomy alone. I wasn't able to fit the mastectomy alone in here in this particular slide. What we found in terms of satisfaction with outcome, first of all, 9,289 women from the AOW responded and were interested in taking this survey, and 7,619 women completed all the questionnaires. So we just feel honored that we had this kind of a result. This is truly the largest patient-reported outcome study out there in the world, and it's because of your efforts. 3,500 patients had the lumpectomy surgery. I sort of interchange in the slide. You'll notice I interchange between lumpectomy and breast conservation surgery. Over 1,200 women had mastectomy without reconstruction, and about 2,800 women had either breast reconstruction at the time of their mastectomy, or they had it in a delayed fashion after their mastectomies. We came up with this group called the Complex Surgical History Group, because these were women who may have had multiple procedures. For example, women who had 2 or 3 lumpectomies that eventually needed a mastectomy, or women that had breast reconstruction that may have failed their breast reconstruction and then resulted in having a mastectomy defect. The reason we created this group, kind of separate from all the other 3, was so that we can try to keep the other 3 groups as peer as possible. So we have excellent data about this group as well, because it's obviously a very important group to look at what their outcomes are. Study participants came from all over the United States, with the greatest proportion of patients coming from the South.
Dr. Atisha, did you have any people who
reported
had...
that they got the majority of them?
Can you hear me? I'm sorry, this is Dr. Love.
Yes.
Any women in there that had oncoplastic breast conservation, or was this just the sort of standard lumpectomy, or could you tell?
We did, and I think, when I look back, I sort of say to myself, I almost wish I sort of separated that group. They were considered under the breast conservation surgery group.
So that's a mixed
but
group.
Yes, they were included in the breast conservation surgery group.
Okay.
And we asked them to essentially, because we didn't include it in the original questionnaire as to whether or not they had oncoplastic reduction. But what we did do is leave an open comment section in the end. And by the way, 3,600 women left us comments about, anything they wanted to regarding their treatment, and that was just wonderful to read those. But they did tell us that they had oncoplastic reduction in the comments.
Okay. Sorry.
So that's okay. This is looking at institution type. This is a very interesting, this is really interesting to me. About almost 50% of women get their cancer care at a community hospital or a community hospital-affiliated cancer center. And, that is the majority of where women get their breast cancer care. Yet a lot of the sort of data out there and a lot of what we do is often related to, either academic centers or big cancer center type of cancer care. The university hospital was next in line. That's where, or a university-affiliated cancer center is where the majority of women got their cancer, and then a place like a standalone cancer center, to name a few. There's the MD Anderson, Sloan Kettering, Fox Chase, Moffitt. There's many all over the country. This is the description of all the 7,600 women. The mean age, or the average age, was 57.9 years old. 65% of them, I'm just going to round these numbers up, 65% of them said they had a history of radiation. About 60% of them said they had chemotherapy. The majority of women in this study were what's sort of considered early stage disease. So stage 0, stage 1, stage 2. So, this study might be a little bit biased towards patients who had the early stages, but you can still see that about 10% had stage 3 and 1% had, disease that had spread. There was a recurrence rate of about 5% in this population of women, and the non-recurrent second breast cancer is essentially those patients who may have had a new breast cancer on a second breast or developed a breast cancer that they felt was completely separate than the original one in the same breast.
And the recurrences include local recurrence after mastectomy as well?
Yes.
Okay.
Yes, they do. This is the breakdown of your the socioeconomic status as well as race and ethnicity. So, the majority of people were Caucasian, white, not Hispanic. Majority of people were either married or divorced. The income level was, with the Army of Women population was higher. It was middle class to higher. The majority of women were educated, and women were either employed or they were retired. That was the majority of the population that was in this study. So this is a breakdown of the different types of procedures that women had. Like I said, the majority had breast conservation surgery, so 3,500. So that's 46% of the population, which I think is pretty consistent with what's out there in the literature about the types of operations that women end up having for their breast cancer surgery. 17% had mastectomy alone, and 30% had reconstruction. And then there's a 7% population here that had the complex surgical history. So of the breast reconstruction procedures, I also broke it down into the different types of procedures because, at least as a plastic surgeon, I know very well that patients who have different breast reconstruction procedures have very different outcomes, and they have very different satisfaction with their outcomes. And they also have very different investments into how much time and effort they put into their breast reconstruction process. And so I felt that, unlike a lot of the studies that are out there, I felt that it was very important to look at the breast reconstruction group as a group that's broken down into their own individual procedures. So about 50% of patients had the expander implant route, and another 23% had the flaps that come from the belly, which is using your own body tissue instead of having to use an implant. This group here, this is a lot of sort of acronyms for big, long, fancy. These are basically butt flaps, gluteal flaps, and thigh flaps. This is the group of breast reconstruction patients that had a complex reconstructive history that perhaps started off with implants and then ended up having to use their own body tissue. This is a group of patients here, the latissimus dorsi patient population, where we used their back muscle and an implant to reconstruct them. And then there was a group of about 3%, or about 83 women, who didn't really know exactly what to categorize their reconstruction as. Since we found that BMI, or body mass index, or patient weight relative to height, was actually an important factor in some of the outcomes we will see later, we felt that it was interesting to look at how patient procedure type was affected by body mass index, and we found something quite interesting. In fact, we found that the more your weight increased from the normal to the morbidly obese category, the higher the rate of mastectomy without reconstruction. So patients were having an increasingly high rate of mastectomy if the more your weight category increased, and they had a progressively lower reconstruction rate. And then interestingly, in the low BMI category, which actually this makes sense, these women had a higher mastectomy rate. Had a higher reconstruction rate, but they actually had quite a low mastectomy rate. And what you're going to see is that, and what was true for reconstruction is that the higher the weight category, the higher the rate of using your own body tissue.
Because you had more to share.
More to give. That's exactly right. And also, implant reconstruction is not exactly wonderful for patients who are in the sort of larger weight category. So here's some other procedure-related data. This was the percentage of women in our entire cohort of women that had a prophylactic mastectomy, so removal of a breast that doesn't have breast cancer in it. And this is becoming much more common. Perhaps much to some dismay, but it is becoming much more common because of genetic testing. I think because of patient education. It is definitely, in our population of patients may even be slightly higher than the rest of the population in terms of the rate of prophylactic mastectomy. The majority of patients had immediate breast reconstruction, which is actually wonderful. That's always what we try to do if we can. If there isn't a cancer reason why we should delay it, then we usually try to aim for immediate breast reconstruction. The time since surgery was, on average, 15 years or less. So since this was just one snapshot of time, we had to categorize sort of at what time point people were from their surgical procedure. And most women were from, less than 1 year to 15 years out from surgery. The majority of women did great without any major complications. 92% of women didn't suffer any major complication, and about 8.5% did have a major complication. And a major complication is something like either a heart attack or a blood clot or pneumonia or anything that required hospitalization or an additional surgical procedure. Those who had minor complications, there was about 27% of women who had minor complications, and that really included something like a wound infection or a fluid collection. Anything that didn't really require any kind of aggressive intervention was considered a minor complication. So these are the satisfaction scores of the entire cohort of women that answered the questionnaires, and I did break it down into the different procedures, including the different reconstructive procedures. So the majority, these are their mean satisfaction scores. So that means the average score, after we counted all of their responses, the points for their responses, they could have scored between 0 and 100. So the patients who actually had the highest satisfaction out of the entire breast cancer surgical cohort were women who went through flaps with either their gluteus, thigh, or their abdomen. So this was actually kind of a surprise because these are women that have had mastectomies and then also underwent, really intense types of reconstruction. Yet they scored significantly higher than women who had breast conservation surgery.
I think that's where knowing whether they had oncoplastic, which means using plastic surgery techniques to do the breast conservation, as sometimes even reducing the other breast to match, or things like that, might might increase that breast conservation surgery. If they just had a lumpectomy without, in the old style, general surgical, just take it out style that then the cosmetic results are not as good.
I would definitely have to agree with you. Unfortunately, that's still not a very common occurrence today for people to have oncoplastic reductions or contralateral symmetry procedures. It's actually only usually tends to happen, I think, at sort of big cancer centers or places where there is a lot of support and immediately available plastic surgeons. Even though there are some general surgeons.
Yeah, a lot of the breast surgeons now are being trained in how to apply plastic surgical techniques into how they do their lumpectomies and
no, I know. There's still not as many of them doing that, and there's still not as many of them doing the contralateral symmetry procedures. So I do agree that breast conservation surgery. If I had broken this up, actually identified the oncoplastic group, it would have been better for our knowledge. In hindsight, it's always better than foresight. So there were so many things I wish I could have done differently about the study. But anyways, these are just mean scores. So what that means is that we didn't actually take into account anything that could potentially be a potential confounding issue. And what that means is, perhaps people in the breast conservation surgery group, they have a higher rate of radiation, or perhaps they have a higher rate of chemotherapy, or perhaps women had, later stage disease in some of the other groups. So we had to take into account a lot of different factors that could potentially affect a woman's satisfaction with their breast, including things like, their marital status, their work status, their income level, their education, perhaps even including things like, obviously, their treatment, what kind of treatment did they get, their stage of disease. So when we took into account all potential confounding variables, what we found is that when we looked at satisfaction compared to breast conservation surgery, since that's kind of the most common procedure, and we wanted to really see what the outcomes were when we looked at the different procedures compared to lumpectomy, we found that still patients with either gluteal or thigh flaps or abdominal flaps had significantly higher rates of satisfaction with their outcome compared to those who had breast conservation surgery. Women with latissimus flaps, which are the back flaps, had similar rates of satisfaction to those of breast conservation surgery. However, women who had implant-based reconstruction had significantly lower satisfaction with their outcome compared to women who had breast conservation surgery. They scored an average of 8 points lower. Okay, so the question is, okay, so who cares? They scored an average of 8 points lower. Is that actually clinically significant? And some of the work that Dr. Pusick is doing, Dr. Pusick is the one who designed this survey. There is, they have done some studies now to suggest that about a 5-point difference is considered clinically significant. So patients who had mastectomies with implants were not as happy as those that got to preserve their breast. Those who had a complex surgical history were not as happy as the breast conservation group. And then those who had mastectomy alone without reconstruction actually demonstrated the sort of least amount of satisfaction with their outcome.
Did you have you looked at this vis-a-vis how far out they are, how long it's been? Oh, here it is.
Yeah, this included, and you're going to see it. Yeah, these are all the, amongst the several factors that we included in the regression analysis. But, the beautiful thing about having 7,600 patients respond is, you get to throw 5 million variables in your regression.
Yeah, you can look at all. Yep.
And so, here are, these are just the significant factors. I could not even, begin to list all the other non-significant factors. So what we found is that, chemotherapy decreased patient satisfaction with their breast. Radiation therapy, also did. Higher stage disease did. Recurrence rates, those who had minor complications, interestingly, were more concerned about their satisfaction with their breast compared to those who had major complications. Time since surgery, so the further one was out from surgery, the the lower their satisfaction was. But it's
you'd think you'd get used to it after a while.
You would think so. I know. And this represents the entire cohort. I think if we were to look at the different procedure types and to do this analysis, we might find different results, for the different types of different types of procedures. I can tell you that when you're comparing implant-based reconstruction compared to abdominal-based reconstruction like the flaps, women who have the flap surgery when they're further out continue to remain satisfied, whereas those that have the implant-based actually have a continuous decrease in their satisfaction. So BMI negatively impacted satisfaction, and then these were, and also this was supposed to be in the green category because it was, I don't know, I messed that up. So this also negatively, being either, being disabled and not being able to work full-time significantly decreased satisfaction with breast. Now, some of the factors that improved satisfaction with breast were higher incomes, those who, were able to do voluntary work, those who had a higher education also seemed to have higher satisfaction, and then those who were actually currently being treated. This is one that I felt was, just amazing. People who were currently undergoing breast cancer treatment, whether it be radiation, chemotherapy, or surgery, actually reported higher satisfaction rates with their outcome. When we looked at the different weight categories and looked at satisfaction, this is a really confusing slide, so I'm just going to break it down. Essentially, it says the same thing as our other slide. It says that women in all weight categories were more satisfied with their abdominal flap, their belly flap procedure, or their thigh or their gluteal flap. Okay, so still says the same thing. And this is compared to, once again, compared to the lumpectomy population. So it still says significantly higher satisfaction with abdominal flap and gluteal flaps compared to lumpectomy patients. It still says that the latissimus flap across the board had similar satisfaction compared to lumpectomy. It still says that patients with implants were less satisfied compared to those that with lumpectomy. It still says that those with mastectomy alone were significantly less satisfied compared to the lumpectomy population. And it still says that those with a complex surgical history were less satisfied than those who had lumpectomy alone. So why is this important? This is important because if you remember that one slide where I showed you that, mastectomy rates went up in patients who had who were overweight or who were obese or morbidly obese, but yet reconstruction rates went down. And in patients who had low to normal weight, they had significantly higher reconstruction rates. So we're offering, it seems that what's happening is that, those who are thinner are getting offered breast reconstruction, but women who are in the, obese or morbidly obese category are demonstrating significantly high rates with their high satisfaction with their reconstruction, but they're not getting offered it as frequently.
You think that's just the biases of the surgeons?
I think it's the biases of the surgeons. I do. I think. I also think what we also found was that women who were in the higher weight category also had higher stage disease on average. I didn't put that data up there, but there was a difference in their stage. However, we did account for stage when we did the regression analysis. So this is the quality of life data. Now, if you remember, I don't know if you remember, but we asked questions about physical functioning, sexual functioning, and psychosocial functioning. So these are three things that are contributing to one's quality of life, at least based on all the studies that have been done. These are sort of the common three categories that a lot of quality of life surveys are focused on. So once again, this is one of these regression analyses where we took into account all the potential things that could affect the score. So by taking them into account statistically, theoretically you should be getting a more realistic, impression of how the different procedures affect the different quality of life outcomes. Okay? So I'm going to just talk you guys through this because I know this is a complex slide. So compared to breast conservation surgery.
The cliff notes.
You guys have the cliff notes? You want the cliff notes? Okay. Well, let's...
No.
Well,
just the
I'll just tell you quickly.
Go ahead.
I'll try to be quick about the cliff notes. So for implant-based reconstruction, actually they did quite well. This is what I find very interesting. They were happy. They had better improved physical well-being of their chest and their upper body. So their functioning of their chest and their upper body actually was higher than patients who underwent lumpectomy. Probably because they have a decreased radiation rate. I don't know the answer to that because we do account for radiation, but they seem to have a very good outcome with their physical well-being. On the other hand, they scored much lower regarding psychosocial functioning and sexual well-being. The patients who underwent the back flap did the same as those who had breast conservation surgery in terms of their physical well-being and their sexual well-being, but they reported lower psychosocial functioning. Those with abdominal flaps had significantly better physical well-being of their chest and their upper body, and similar psychosocial well-being and sexual functioning. So these are, once again, women that had mastectomies with abdominal flaps had similar sexual well-being and psychosocial to those with lumpectomies and higher physical well-being. Those with the thigh flaps, same thing as the abdominal flaps, same thing as what I just said. Those patients who had mastectomy alone actually had improved physical well-being of their chest and their upper body because they just were comfortable with their chest and their body, and their functioning was okay. On the other hand, if you look at their psychosocial functioning and their sexual well-being, they were, amongst the lowest in terms of what they reported about these two particular outcomes. And then the complex surgical history group had similar findings to the mastectomy group, except there was no difference in their physical well-being of their chest and their upper body.
Doctor,
so other factors.
Do you think, how much do you think, or did you really get into sensation, since one of the big differences with all of these kinds of reconstruction versus breast conservation is the lack of sensation?
In terms of sexual well-being?
In terms of sexual well-being, yeah.
I think it didn't necessarily focus on sensation of breast, but perhaps I think the questionnaire is actually focused more on sort of comfortability, with partner, and ability, and sort of desire, and things like that. And I don't know. I have to look back at the questionnaire and actually look to see if there was a particular question about sensation. Are you saying because the lumpectomy patients would have a higher rate of sensation? Well, they
still have sensation, nipple sensation and sensation in their breast, and all of the mastectomy reconstruction patients don't.
But they're actually not having any different results in their sexual well-being compared to those who had autologous tissue reconstruction. So if you look at this, this is basically saying that doesn't necessarily matter, that women with abdominal flaps, gluteal flaps, and even the back flaps all reported similar sexual well-being. So this is probably, a little too researchy, so I'm just going to keep moving on. Okay, so in summary, this is the largest study to date evaluating patient-reported outcomes in women undergoing breast cancer surgery. And there is a perceived difference in satisfaction with breast cancer procedures. It favors those who have had belly flaps or thigh flaps. That's autologous tissue, means using your own body tissue. Approaches over lumpectomy, and it favors a lumpectomy or reconstruction over just having a mastectomy alone. Positive factors such as higher education and income did improve satisfaction. And then, although all women, regardless of BMI category, experienced higher rates of satisfaction with using their own body tissue compared to lumpectomy patients, increasing BMI actually resulted in lower rates of breast reconstruction. Those who had reconstruction, other than with the back flaps, reported higher physical and chest wall functioning than those who had lumpectomies. And using your own body tissue resulted in similar sexual and psychosocial well-being as women who had lumpectomies. On the other hand, women with implant reconstruction, mastectomy alone, or a complex surgical history actually reported lower psychosocial functioning and lower sexual well-being compared to women with lumpectomies. So personal characteristics like increasing BMI category, therapies such as radiation or chemo, radiation in this case, features reflective of worse disease such as stage 3 disease, and minor complications tended to erode breast satisfaction and all of the quality of life outcomes. An increase in patient age and longer times from surgery actually significantly improved just QOL, but not satisfaction. So what's the big deal about all this stuff? Essentially, these results really underscore the importance of informing patients about all of their options regarding their breast cancer surgery. And I'm not really sure how great of a job we do with this at today's day and time. It really is an informed consent process, and women should, particularly if they have early stage disease and if the cancer allows it, women should really be given all of their options up front, and they should have the ability to make the decision about what route they want to take. So consultation with a plastic surgery should take place before women make the decision between a lumpectomy or a mastectomy. And there really is it's an important discussion that needs to also involve the medical oncologist as well as the radiation oncologist. These are some of the manuscripts that we have recently published. We are in the process of actually preparing the following publications. The next sort of big publication that's going to come out is the National Snapshot of Quality of Life Outcomes. I showed you some of the effect of obesity on procedure selection and satisfaction with breast cancer surgery. We're also looking at comparing patient-reported outcomes for those who had a mastectomy on one side versus those who also did the prophylactic mastectomy. And we're looking at the PTSD data. That's the data I didn't have for you today because I don't actually have it back yet. But I think that this is going to be very interesting to see if procedure type actually affects PTSD. And then we're also looking at whether or not different types of abdominal flap procedures, like the DEEP flap, which is some of the newer types of abdominal flaps we do, and the pedicle tram flap actually have a difference in their abdominal wall satisfaction. And I just want to acknowledge Dr. Abernathy, who is my co-investigator on this study. She is a medical oncologist at Duke, who is an amazing researcher, and she's been a great mentor. Dr. Greg Sampson, Crystal Rushing, did an amazing job with these statistics. This was a very complicated database with, hundreds of thousands of variables, so they had a very difficult job. Dr. Tracy Locklear works with Dr. Abernathy and was a great asset to the research team. And Dr. Andrea Pusick, who's at Memorial Sloan Kettering, is also a plastic surgeon who's very interested in patient-reported outcomes, and she was the developer of the BreastQ. This study was supported by a grant from the Plastic Surgery Foundation and some of the discretionary funds that I had in my division here. But most importantly, I wanted to thank Dr. Susan Love for even accepting this study with the Army of Women, and then just to the Army of Women who have done so much to help me. I wish you guys could have sat and read some of the comments that patients made, the 3,600 comments, just going through and listening to women's stories and having them tell me, why they felt that this study was important and how they hoped that it would impact the future of breast cancer care. So thank you very much.
Thank you.
Thank you so much.
We have some questions and that we'll get into. And one is, I realize this is outcomes, but somebody observed that women who are obese sometimes have a lot of other comorbid disease, and so they may not be offered what they want, which is a bigger operation.
Yes, that could be very true. Unfortunately, we don't, I do have comorbidity data, but was not able to get that together for this particular regression. But I do think it's probably really important to include that. We did include stage of disease, and one thing that women do have, the higher, more, obese and morbidly obese women did have higher stage of disease when they were diagnosed. So I definitely think that that's important. I do think, though, however, there probably is a little bit of a surgeon and physician bias associated with this. It's way more difficult to reconstruct a larger patient, and oftentimes they don't get great outcomes from just implant-based reconstruction. And so they have to get the flap types of surgery. And not everybody in the country is, really able to offer the flap types of surgery, particularly, plastic surgeons who are either not comfortable with it or just don't have the support to do it.
Yeah, that we had a question on that. The geographic availability of the reconstructive surgery could also impact what decision you make.
Absolutely, it can. And I think that this is a an issue, unfortunately, related to reimbursement. And I mean, it's sad for me to say, like I'm, to me, my existence on this earth is for women who have breast cancer and wanting to reconstruct them. But I work at a university, and so for me it's easy because I'm salaried. And unfortunately, a lot of the private practice doctors out there don't have the kind of support that they need to be able to run a very busy reconstructive practice. And so because they make significantly less than what they can make, and they cannot afford to run an office sometimes based on that. And I hate to say that that's part of it, but these have to do with reimbursement issues. Even though Congress did make an act saying that all women deserve to have breast reconstruction, availability of plastic surgeons all over the country, particularly in small towns, is not always feasible.
And that brings me an early question that we had was having reconstruction after a partial mastectomy. That their insurance refused to pay for it because it wasn't a mastectomy. So that's another issue that sometimes you could have you could do some reduction on, as we said, do oncoplastic, do reduction on the other side, or fix maybe if you have a divot you could fix that up a little bit, but insurance often won't cover that.
I think that in the past there was definitely a lot of issues with insurance companies covering contralateral procedures, so that means procedures to the side of the breast that didn't have the cancer. But I think that there have now been newer laws to support doing contralateral procedures in women with a history of breast cancer for symmetry purposes. So if that ever happens to a surgeon, or if that ever happens to me, and we get sort of a refusal from the insurance company, I try to call them and do the best that I can to help them understand that that's not legal. That they are required to cover a symmetry procedure in a patient who's had radiation and a breast cancer treatment on the contralateral side. So sometimes it takes a little bit of pushing on the part of the patient and the surgeon, but unfortunately, it's difficult to predict especially with all the changes that are happening with insurance companies today. And I think that's why we as plastic surgeons and as breast surgeons and sort of all of the breast cancer world need to stay very active in politics. Because these are, with all the changes that are being made in healthcare, I mean, these are the kinds of, we really need people to stand up for women. And these are the kinds of studies that are going to help us prove our point. These are women telling us, like, this is what we're living with. And we support, plastic surgeons, or we support, oncoplastic reductions or contralateral symmetry procedures because it has an impact on our life.
Absolutely. And it brings me to somebody asked if you had an advocate involved in the study design and interpretation or not.
A lawyer? Is that
no, a breast cancer advocate, somebody who's been through
yes, it. I did. Okay. Yes, actually, unfortunately she's not on here because Sophia Smith was a breast cancer survivor, and she was somebody who used to work for Dr. Abernathy, and she was involved with designing the study.
Okay.
She unfortunately has, since left to a different department. But she was the one who, in fact, recommended that we also look at PTSD.
Right.
Since that's sort of some of the newer findings are that that patients with lymphoma, patients with breast cancer do experience PTSD, and it needs to be recognized.
Another question is the demographics, particularly those of the lower income. Do you believe the statistics are directly related to the lower income status? Likely means lack of insurance and other financial resources to pursue treatment.
I definitely I think that availability of yes, I 100% agree with that statement. Yeah, I do believe that it has to do with the ability to pursue treatment, surgeons, finding plastic surgeons, not necessarily getting the multidisciplinary care that they need. Somebody asks if there's any surgery that can save your nipple. Do you want to speak to nipple sparing mastectomies? Sure. Yeah. Yes, there are excellent procedures that can save your nipple, and in the nipple-sparing mastectomy is one of those. Not everybody is a candidate for those. Every institution sort of has their criteria, but the nipple needs to be sort of far enough, or I'm sorry, the cancer needs to be far enough from the nipple that it would be safe. One needs to not have sort of diffuse disease or diffuse DCIS, and they need to not have too much droop of the nipple. So that's sometimes called, in medical terminology, called ptosis, because the nipple has to survive sort of with just the skin and after we've removed the breast tissue. So the droopier the breast, the higher the likelihood the nipple won't survive. So it's really a discussion between the cancers.
I was going to ask if there's sensation in the nipple.
What about sensation? So that's an excellent question because we're actually doing a study on sensation, right? Is that what you're asking?
Yeah.
Initially, the sensation is gone, completely gone, but we are currently doing a study right now at Moffitt looking at, patient sensation with nipple and skin-sparing mastectomy, and we're doing it sort of prospectively, so we're waiting 1 to 2 years out. But, I can tell you from my own experience that women will eventually gain pressure sensation. They might even gain pain sensation, but they don't typically ever regain sexual sensation in the nipples. The patients report the highest satisfaction with being able to spare their nipples, by far and away, even if we do nipple reconstruction. Being able to spare the nipples is really, I think, it tends to have the highest satisfaction with reconstruction. But there are, unfortunately, not everybody is a candidate for it. And the most important thing is, is it safe from a cancer standpoint? And so those are just discussions that your cancer breast surgeon and your plastic surgeon would need to have together.
A question about whether in the people with implants, did you look at whether they had to have the implants replaced?
So that was the did we look at whether or not they needed the implants replaced?
Yeah, so
no,
we did not ask them. Implants have to be replaced, yeah.
Yes. We did not ask them that particular question.
Okay.
But my suspicion is that a lot of the satisfaction with outcome and some of the quality of life outcomes that were a little worse, compared to the breast conservation group was probably because they're a little bit higher maintenance. And also because I think some women report that they're not super comfortable sometimes. You're having to stuff a relatively large prosthetic in underneath a muscle, and it doesn't mean that they're a bad type of reconstruction. We certainly see that throughout all the results, women have reported that it is better than not having any type of reconstruction. If you can remember some of those, I'll show you just the little graph, this one right here. So if you look at the mean score, it's still higher, significantly higher than those who just had mastectomy alone. But sometimes just carrying the weight of the implant and it pulling on the chest wall causes uncomfortability compared to using your own body tissue.
Mm-hmm. Did you have a breakdown based on patient age of the choice between lumpectomy and reconstruction versus reconstruction?
We did look at just the reconstruction cohort, actually. And are you asking whether or not they were perhaps more satisfied, or do you just want to know about incidence? No, I didn't look at. I mean, age was included in aggression, but I didn't actually look at a comparison of age and whether or not they had reconstruction versus not. I can tell you that in the entire cohort, that age actually had a positive effect on a lot of outcomes. So the older, particularly in the reconstruction cohort, the older the patient was, the happier they actually were with their outcome.
Okay. Let's see. Did you include lymphedema of the arm?
Okay. So there is nothing in the BreastQ or any of the different surveys that we asked questioning patients about whether or not they had lymphedema and how that perhaps would have affected their outcome. I did get a huge number of women in the end comment section that reported that their biggest discontent with everything was the lymphedema that they suffered. from. And I think that is a big drawback of the BreastQ or any of the cancer-related survey questionnaires that we administered. I think lymphedema is a huge important issue. But no, it was not included as a separate variable.
Okay. You can also get breast edema, from the axillary surgery, which also is a problem. Okay, let's see. Some of these are there. Advocates, we have maybe one more. People are, there are some comments, exciting results, and I'm so happy to have been part of this research.
Oh, that's wonderful. Thank you for all of your help.
And good job. Lots of publications from one survey.
Thank you.
So in general, I think some of these other questions we've already answered. But this has been really great, and we particularly appreciate, we do a lot of studies in the Army of Women, and we really think it's very important to be able to get the information back to the people who are in the study, and that often doesn't happen. So we appreciate your being willing to do that.
Yeah. Well, it has been my pleasure and my honor, and hopefully we will work again with each other again in the future.
Yes, and then thank you so much, Dr. Atisha, for joining us and sharing your really exciting and wonderful results. Thank you everyone who's on the call. We will have a recording of this up in the Army of Women website soon, sometime this week, and we will email you all who have joined the call or who signed up for the webinar where that will be shortly. We're so pleased to have everyone online, to have you with us here, and Dr. Atisha. Thank you so much.
Thank you. You guys have a great day.
Okay, thank you.
Take care. Bye-bye.
Bye.